birth?
This ties back into why Kegels are not the best option like during pregnancy. Because when we're giving birth, our uterus is pushing the baby out, not the pelvic floor. So if during pregnancy, we're training the pelvic floor, keep getting it nice and strong. And it's interesting because a lot of women who will reach out to me, like I see what they write like in the inquiry form. And they're like, I want to train my pelvic floor so it can be nice and strong for birth. I'm like, no, we don't want it to be strong for birth. So we actually train the opposite so the pelvic floor can actually lengthen and move out of the way. That's essentially what the pelvic floor's job is.
Okay.
Get out of the way, stretch, lengthen, and be able to actually yield to what the uterus is trying to do. Okay. Now, the nervous system is also part of that as well, because if women step into birth with the mindset of wanting to control every aspect of it and force their way into birth, the body again is going to harden, stiffen, and it's not going to be able to surrender to the entire experience. So we talk through that whole process. But yeah, getting the pelvic floor to fully lengthen is like top priority, which is something that we typically will start focusing on once we get into third trimester. In my birth prep sessions, I actually will work with women to help them practice pushing. So I'll do an internal assessment and I guide them through what it would look like for them to actually push and mimic, not with the same force, but mimic the same movement of what it would be like with their breath pattern to give birth. And it's so interesting because especially a lot of first time moms will be like, okay, like now go ahead and push the way that you would think that you would. Almost 9 times out of 10, they're like, okay. And they do a Kegel. And I'm like, okay, so I'm happy we're doing this because now we can actually train you to do the opposite. Because if you're trying to do a Kegel during birth, you're basically closing the door that the uterus is trying to open. So then now you have this internal battle of the uterus trying to do a job and the pelvic floor making it more difficult. So
interesting. Okay, so to back up a second, you mentioned you do an internal exam, which I think is like an interesting part of this that if somebody's never done it before, they wouldn't know. So you are literally like doing an intravaginal, like you're like feeling around, I'm assuming with a glove, right? Yeah. Seeing how tight the muscles in there are.
Exactly. And it's different than what you experience like when you go to the gynecologist. Like when you go and do a pap smear, they're going a lot deeper. They're going they're doing a pap smear, they're going like into the cervix. When we're doing a pelvic floor assessment as pelvic floor PTs, we're literally going along like the pelvic bowl. So we're going intravaginally, but we're moving a little bit more superficially so we can actually feel the muscles and what they're doing. Okay. So we can see and feel if there's tension along the pelvic floor. So the same way, like in your traps, like when you get tension or you get a knot, for example, you can get the same tension along the pelvic floor as well. So it's really interesting because a lot of times the pelvic floor doing an internal vaginal assessment really will uncover a lot of the root cause of like what a lot of women are experiencing, and they had no idea that it was coming from their pelvic floor. So
that is so interesting. Yeah. Okay. And would that be in every session that you're doing that? Or is that more just like for initial assessment?
Not necessarily. So when it comes to doing internal assessments, it really depends on what the patient's needing. So for example, if a patient comes to see me at the beginning of their second trimester, I usually will do an internal assessment just to get a good baseline. If everything looks really good at that first initial assessment, pelvic floor feels good, there's not a lot of tension, they're not symptomatic, not really experience anything, then we'll typically do like once a month until we get closer and we can increase the frequency. But if there is a true pelvic floor dysfunction where there is a lot of tension, there's asymmetries, that thing, then internal vaginal assessments will be more frequent. But it's very rare that I'm doing internal every single session for every patient. It really is just based on like what the patient needs. So it varies.
Yeah. Okay. Yeah. And then so you mentioned, so a lot of women when they think of pushing, they're like contracting the muscles rather than like releasing. So you're teaching them like, okay, when you think, like when I say push, it's releasing. And then how is that affecting their actual birth process? Because I've seen you post some of the testimonials that you've posted. I'm like, oh my gosh, this like really speaks for itself. So I don't know if you can speak to like maybe some of your patients' experiences.
Yeah, I think when it comes to birth, a lot of it is like education. And like you mentioned earlier, like how you wish like some of the OBs and like some of the doctors would actually talk more about it. And I think that is the biggest gap that we have where they just don't know to come to pelvic floor PT. So when I'm working with my patients, a lot of it is like advocacy, making sure that they're asking the right questions and making sure they actually understand what's happening with each contraction. When it comes to working with my patients, I actually teach them and educate them to push with the contraction, help facilitate with what's going on. And also I have found there's like a gray area because obviously like I want to make sure that the OB or the midwife is leading what's exactly happening.
Right.
But what I do find is that when women typically will wait until they actually truly have the urge to push, things move more naturally and intuitively to them. Then once they're able to actually connect with their pelvic floor, that's when they really are able to see a lot more of the difference and then actually be able to push more effectively.
Okay.
Sometimes what can happen though is if a patient has an epidural where they are completely numb, cannot feel a single thing, that's another way too that there's that disconnect of what the pelvic floor is doing. They can't really feel anything. So it makes it more difficult for them too. So I always try to have them talk to their OB or midwife to see if there's a way to like lessen the epidural so it's not as strong.
Yeah.
Because ideally you still want to be able to feel some sort of pressure. If you cannot feel anything, it's going to be really hard for you to know what's going on.
Because you can do like a walking epidural, right? Where it's like an epidural light.
Yeah, an epidural light. So there are like, and again, that's like more once you get into the anesthesia side. Like I don't know exactly like the dosing or anything like that, but I do know that there's a way to have an epidural. Sensation is significantly dampened and you can still feel, but it's not as heightened. So that's like, again, like a conversation that I typically will tell my patients, like have that conversation with them to tell them like, I don't want to be completely numb. I want to be able to still feel. Obviously every patient's different, like body weight's different. So it's just making sure that they know to ask questions so they can be a little bit more informed with that. But yeah, another thing too is positioning.